Hello, everyone. Welcome to our Zoom meeting. Today we're gonna have different topics. So Dr. Saja is gonna moderate the Zoom meeting. And hello, everyone. I'm gonna hand it over to you, Dr. Saja, when you are ready.
Sure. Thank you so much, Dr. Nader. And thank you so much again for this great opportunity. I'm very grateful to be part of this team. I will start off by letting everybody know that I'll be the moderator for the 5 presentation today. I have them all downloaded on my computer and I'm ready to share my screen. However, please feel free if you want to present from your side. I will save introducing myself for when I am presenting my slides. But first we can start with Dr. Nuha and her team with her first presentation, if she's ready. Dr. Nuha, are you ready?
Yes, I'm ready.
Would you like me to share my screen or would you like to share yours?
I will share mine.
Sure.
Thank you, Saja.
My pleasure.
Thank you. First, thank you so much for this great opportunity. I'm so happy to be part of this. Should I start my presentation?
Yes, please.
Okay. First, my name is Nuha Hussein. I graduated from Al College 2018, and I'm currently a GP in Saudi Arabia. We will talk today about the schizophrenia spectrum and other psychotic disorders. By the end of this session, you will be able to evaluate a person with psychotic symptoms. You will know the epidemiology and clinical characteristics of late-onset schizophrenia. You will be able to evaluate psychotic symptoms associated with disorders other than schizophrenia. Management of older adult patients with psychotic symptoms. Topics will be covered: schizophrenia and schizophrenia spectrum syndromes, psychotic symptoms in delirium and delusional disorder, psychotic symptoms in mood disorder, psychotic symptoms in dementia, isolated suspiciousness, syndromes of isolated hallucinations, Charles-Bonnet syndrome, and other psychotic disorders due to other medical condition, substance and medication-induced psychotic disorder. First, we will talk about the psychotic symptoms. I'm sorry, just a minute. And these defined as either hallucinations or delusions. We will talk briefly about each one. Hallucinations are defined as perception-like experiences that occur without an external stimulus, and they may occur in any sensory modality of the 5 sensory modality. They are auditory, visual, olfactory, tactile, and gustatory. We'll talk briefly about each one. First, auditory hallucinations, or in other words, hearing things. And auditory hallucinations are most commonly seen in patients with schizophrenia. Patients may sense that the sounds are coming from inside or outside their mind. They might be hearing voices talking to each other or feel like they are telling them to do something. Sorry. And this is extremely important because that voices might be telling the patient to hurt themselves or others. Second is visual hallucinations, and these are seeing things. These hallucinations are often seen in Lewy body dementia and drug intoxications. And it's very important to keep in mind when you are making your differential diagnosis of the patient presenting with visual hallucinations. Third is olfactory hallucinations. And these are smelling things are seen in patients with seizure disorders or with epilepsy. A patient may call that they are smelling something burning or something funny, and I think we all seen this. Tactile hallucinations, and this is when individuals feel something or touch sense. And when you have a patient complain of this, you really want to keep in mind that this could be secondary to drug abuse or alcohol withdrawal. Gustatory hallucination, and this is associated with different neurological and psychiatric disorders. Second is delusions, and these are fixed false beliefs that cannot be altered. There are different types of delusions. We will talk briefly about each one. First is suspicious paranoid delusions, and these are irrational beliefs that one is being followed, tracked, or targeted. And an example for this, someone may believe that their neighbors are spying on them. Second is grandiose delusions, and these involve an exaggerated sense of self-importance, power, or knowledge. And a patient with these symptoms may believe that they are famous historical figure or that they having a supernatural abilities. Somatic delusions. These delusions are centered around the belief that one's body is abnormal or malfunctioning. And patients with somatic delusions sometimes believe, for example, that there's insects crawling under their skin or that they have an abnormal organ. Self-blaming delusions, and these are involve the irrational belief that one is responsible for negative events or outcomes. An example for this, believe that a patient may believe that he is responsible for his father's death or his aunt's illness, for example. Last one is hopeless delusions, and these are delusions where a person believes that their situation is bleak and the negative outcomes are unavoidable. And the thing with the delusions that you cannot change the idea that patient had. You can never change it. After we've talked about the psychotic symptoms, we now will talk about how to evaluate a patient with psychotic symptoms. First, in evaluation patient with psychotic symptoms, you have to evaluate for underlying medical causes and exclude that, such as delirium, dementia, a stroke, Parkinson's disease, or substance abuse disorders. These all diseases present with psychotic symptoms. Acute onset of altered level of consciousness or inability to sustain attention usually suggests delirium, and this is often superimposed with an underlying dementia, which is the most common cause of new onset psychosis in late life. Second, you have to exclude other primary mood disorders, such as major depressive disorder or bipolar disorders, because these diseases also presents with psychotic symptoms during certain phases of the illness. So finally, the diagnosis of schizophrenia spectrum disorder should be considered after ruling out all the potential causes of psychotic symptoms. So it's a diagnosis of exclusion. Schizophrenia of late onset, sorry. So what is schizophrenia? It's a chronic psychiatric disorder characterized by positive and negative symptoms, usually beginning in late teens or 20s. And by positive and negative, it do not mean good or bad. Instead, positive means an addition of something, and negative means an absence of something. So positive symptoms of schizophrenia refer to an addition or excess in atypical behavior or emotion. And negative symptoms refer to absence of typical behavior or emotion. And example of positive symptoms are hallucinations, delusions, thought disorders. And example of negative symptoms are social withdrawal and apathy. Schizophrenia-like syndromes of late life. It's different from schizophrenia of early life in some points. It's onset usually after age of 40. Late onset, female to male ratio ranges from 5:1 to 10:1, means that female are mostly affected. And there is prominent paranoid delusions and multimodal hallucinations in the schizophrenia of late life. The differences from early onset schizophrenia, it's a much lower incidence of thought disorder, and the personality and social functioning are often better preserved. Thought disorder. Simply, thought disorder, it's an impairment in the organization and presentation of thoughts, characterized by clinical signs such as illogical thinking, incoherence, and poor use of linguistic context in speech. And there is two charts. The first chart present 5% of cases of schizophrenia-like psychosis present with thought disorder. Second chart present in 50% of cases of early onset schizophrenia. This means that the onset of thought disorder in early onset schizophrenia much higher incidence in comparing to late onset schizophrenia. Symptoms of late onset schizophrenia. Unlike individuals with early onset schizophrenia, many people with late onset schizophrenia-like psychosis have been able to hold a responsible job, marry, or have long-term relationships because they have mostly preserved social functioning more than patients with the early onset schizophrenia. But pre-morbid symptoms are common, isolation, schizoid traits, and these are social detachment, restricted emotional expressions, and introversion symptoms. So now we'll talk about the non-pharmacological management of late onset schizophrenia. And because the suspiciousness and paranoid delusions are commonly the most prominent symptoms of schizophrenia, so the doctor's first task is to establish a trusting therapeutic relationship with the patient. Because symptoms are usually frightening and distressing to the patient, suspiciousness also can isolate the patient from friends and family. Therefore, encouraging patients to maintain important relationships and seeking their permission to discuss the source of symptoms with closely friends, family members may help these patients maintain important and supportive relationships. Well, thank you for listening. My colleague will continue. Dr. Sameera.
Hello, everyone. Good afternoon. My name is Dr. Sameera Mohammed. I will be continuing the presentation. So pharmacological treatment of late onset schizophrenia. Typically, we treat schizophrenia with using antipsychotic drugs. There are two classes. There is the first generation antipsychotic and the second generation antipsychotic. Um, Antipsychotic drugs are effective in the late onset schizophrenia, as in early onset cases. Increase dose semi-weekly or weekly as needed. Responders should continue for at least 6 months. For patients who relapse on treatment or when the dose is lowered, maintain treatment for at least 1 to 2 years. So we monitor for the extrapyramidal symptoms such as Parkinsonia, tremors, dystonia, and rigidity. And we should usually avoid polypharmacy by reducing or switching medication rather than adding or adding a medication for extrapyramidal symptoms. We can consider also concomitant anticholinergic medication. We usually use the second generation antipsychotic because they have less side effect, the extrapyramidal side effect than the first generation, but they can have some metabolic side effect. They are like olanzapine. Mainly they increase weight gain. And this chart demonstrates that different type of antipsychotic and the doses and side effect related to them. But in general rule, the first generation antipsychotic more likely to cause extrapyramidal symptoms, and the second generation are likely to cause a metabolic syndrome. All the listed medication have a warning about hyperglycemia, cerebrovascular event, and increased all-cause mortality in patients with a dementia. Okay, next slide. We have the common side effect we have other than extrapyramidal symptoms, we also have tardive dyskinesia, acute dystonia, and then tremors. Because the antipsychotic medication, schizophrenia have increased excess of dopamine in the brain. We block the dopamine, and when we reduce the dopamine receptor, dopamine level in the brain, we can induce a Parkinson, because Parkinson, as we all know, have a reduced level of dopamine level in the brain, in the substantia nigra. So a tardive dyskinesia characterized by repetitive involuntary movement of the oral and the limb musculature. Older age is predisposing factor. When an antipsychotic is started, or as soon as the symptoms improve enough that the patient can understand the risk, and educate the patient about the tardive dyskinesia and the potentially that it can be irreversible. So the only FDA approval since 2017 is Velapansine, the first medication. But we usually try to first reduce the dose and see if there is the psychotic symptoms appear. If the patient is stable, we educate them when they come out of psychosis. If not, we can add the medication to treat the side effect. So now we talk about the psychotic symptoms in delirium. We know that delirium happens in a lot of medical condition, and it is lapse of cognitive effect during that relapse and remain. So what are the psychotic symptoms in delirium? We have hallucination, particularly visual. They can be symptoms of delirium even when it is mild. Onset is usually acute, and there is often an identifiable metabolic or infectious cause, mainly sepsis or hypertension, and other so on. And mental state examination reveal there is multiple cognitive impairment. The patient cannot, he is not oriented to time or person or place. He cannot understand you, or sometimes he is not coherent what is happening around him. There is also diminished or waxing and waning level of consciousness. So the whole mark is impaired attention and the level of awareness in psychotic symptoms with a delirium. Now we talk about the psychotic symptoms in delusional disorder. What is delusional disorder? Delusional disorder is a long-lasting chronic delusion without hallucination. So the patient usually just suffer from a delusion, a specific one, but the patient have a normal mood and no cognitive impairment. We usually describe the patient as having specific delusion that is believable not so severe, and most patients have normal functioning. They usually work. They just have a fixed delusion. It is more frequent among women, but more severe among men. Like sometimes they have a delusion of jealousy, of being followed, suspiciousness that people trying to get them or hurt them. Delusion are most commonly persecutory, as we mentioned, or paranoid, but can also be delusion of jealousy or somatic delusions. Management includes reassurance, amelioration of the sensory deficit. Sometimes antipsychotic may be needed. Psychotic symptoms in mood disorder. So we know that there is mood disorder can be either bipolar, depression, mania, cyclothymia, and all that. The mood element happens. When we have a mood disorders and we have a brief episode of psychosis within the longer period of the mood disorders, we call that mood disorder with the psychotic symptoms. The delusions in the mood disorders usually mood concurrent. What does mean that it is similar or goes with the mood itself. So if the patient is depressed, the mood the delusions will be like delusions like self-deprecation, self-blame, worthlessness, hopelessness. And if the patient is like a manic or it will be have a grandiose delusions or superpowers or like you can do everything. So according to the mood, the psychotic symptoms, especially the delusions, will be similar to it. Okay. So patient with psychotic symptoms with in dementia. Patient with dementia experience both hallucinations and delusions, usually less complex than delusions seen in schizophrenia or mood disorders. So patients suffering dementia, when they have hallucination or psychotic symptoms in general, they are less severe. They not like when a patient actually have a full-blown psychotic disorders or psychiatric disease. So common delusions in dementia believe that one belongs having been stolen. So you think your belongings are being stolen, or conviction that one is being persecuted, either by family member or the FBI. Believe that one spouse is unfaithful. So. Yeah. So how we manage psychotic symptoms in dementia? We use antipsychotic in the setting of warrant careful consideration of the risk and the side effect, because antipsychotic have a major side effect, and we are treating older people with dementia, so they are more likely sensitized, or as we all know that antipsychotic, anticholinergic, and like carbamazepine, anticonvulsant medication all have heightened effect on the older population. So we first try the non-pharmacological interventions, such as redirecting the patient and reassuring them, should be tried first. If the patient is physically aggressive or severely distressed by the psychotic symptoms, then a trial of low-dose antipsychotic is warranted. We usually try a second-generation antipsychotic and a very low dose. All patients with a psychotic agent can carry an FDA warning regarding that all-cause mortality in patients with dementia. Psychotic disorder due to another medical condition. So as we have been through the presentation, we know that we have schizophrenia, as we mentioned, mood symptoms or mood disorders with a psychotic element. Sometimes the psychotic is due to medical condition, like you have a liver damage or you have a brain stroke or something like that. So delusion and hallucination without prominent cognitive impairment that are likely to be a direct result from another medical condition rather than to do a psychiatric disorders. In this situation, we describe this disease as a psychotic disorder due to another medical condition. It often occurs in patients with brain disorders such as Parkinson's disease or stroke. Exclude delirium due to superimposed condition. We must know that the patient is not suffering just from delirium. Delusions and hallucination may be secondary to anti-Parkinson agent, but some experience visual hallucination prior to the onset of any medication. So, as we know that even the medication could be the cause of the delusions and hallucinations. So we like trial of removal the medication and see if the patient is just having the pure psychosis or it is a side effect from the medication. Just this, just this discontinuation of the dosage reduction of non-essential antiparkinsons meds often provide relief from the psychotic symptoms. Psychotic symptoms disorders due to another medical condition. First generation antipsychotic may worsen Parkinsonia symptoms. Partially try antipsychotic off-label if the patient experience significant emotional distress. Symptoms lead to dangerous or upsetting behavior. Consider amivarcine for the treatment of psychosis in Parkinson's disease. Now we talk about permanent and visual hallucination are often vivid and trembling and are key diagnostic features of dementia with Lewy body. Patients with dementia with Lewy body have heightened sensitivity to antipsychotic medication, including worsening extrapyramidal symptoms. There is no trial data available to guide the drug choice. These are cases report of significant improvement with a cholinesterase inhibitor, but are all off-label. The non-pharmacological treatment are a redirection and reassurance and explanation are the best approach. Okay. So now we talk about the substance-induced or medication-induced psychotic disorders. Now, this is a diagnosis when the drug itself is the cause of the psychotic. Drugs of abuse can cause resistant psychotic symptoms after the period of acute intoxication or withdrawal. So the emphasis here is that we make the diagnosis not when the patient is actively intoxicated, because some like alcohol, cannabis, and cocaine can do have a psychotic or psychotic element in the intoxication period. But even if you abuse cannabis for a long time and then you stop the cannabis, you develop psychotic symptoms. We say that this is substance or medication-induced psychotic disorders. Many classes of medication can cause hallucination also or delusions like beta blockers, interferon, cyclosporine and steroid, antiarrhythmic, antiviral, opioid, antineoplastic medication or agent, and like baclofen and others. Okay. So now we talk about what is isolated suspiciousness. It's a diagnosis when the suspiciousness is inherently a personality trait common to all human, but in varying in permanence and how it is appearing in every individual, may become more common in those over age more than 65 years. And we distinguish this from other psychotic disorders. We exclude, we exclude all other causes. So we understand the understandable nature of the idea because they are less severe than the other delusions or psychosis. So the patient will be just excessively worrying or have about safety or about health of his health or his other people health, and the absence of other psychotic symptoms. So there is no like hallucination or auditory, olfactory, visual. Just the patient is suspicious. We call that isolated suspiciousness. Okay. There is isolated hallucination, a condition called Charlie-Bonnet syndrome. It is usually happen when the patient suffer from a visual loss or have macular disease, macular degeneration, and it occur in older population mainly. And the criteria for the syndrome are the visual loss, as we mentioned, and patient develop visual hallucination. The hallucination can be happy hallucination or bad hallucination. The hallucination can comes and goes, and the patient can have an insight or not. So what is an insight? It is when the psychiatric patient or the client know that he is suffering from a condition or not. So when when the insight is intact, he know that what he's seeing is not real and it is only like a mind trick or a visual hallucination. patient varies, can have a fully intact insight or lack of insight. Lack of evidence of brain disease or other psychiatric disorders make the diagnosis of Charlie-Bonnet syndrome. It is usually affect 10 to 13% of patients with a bilateral acuity less than 20/60. So the management of the syndrome, the best treatment is information and support. We educate the patient about his condition, reassure the patient that the hallucinations are signs of eye disease and not a mental illness. And a few patients have a partial insight or lose insight and become very distressed by the symptoms. When this distress is significant or lead to dangerous behavior, we cautiously try a low dose atypical antipsychotic is occasionally beneficial. Now my colleague will continue the presentation. Thank you all.
Hello, I'm Abdulrahim Ibrahim. I'll present the summary and the cases. We'll start by the summary. Psychotic symptoms are defined as either hallucinations or delusions. Psychosis occurring for the first time in late life is often due to neurological conditions such as dementia or stroke. 10 to 15% of cases of schizophrenia first come to clinical attention after age of 45. Only after other medical and mood disorders are excluded should a diagnosis of schizophrenia-like psychosis be made. Antipsychotics are as effective in late-onset schizophrenia as in early-onset cases. When psychotic symptoms arise in patients with depression or mania, the symptoms are mood congruent. Dementia with Lewy body is associated with characteristically vivid visual hallucinations, often consisting of people or animals. Antipsychotics should be used quite cautiously in patients with dementia or Parkinson's disease. Also, now we'll move to the cases. We have 3 cases, and we'll be happy to hear your answers in the chat. So I'll start with the first case. An 82-year-old man has become increasingly disruptive in the dining room at his nursing home. He accuses staff and other residents of conspiring to poison his food. His table mates have moved away and staff has stopped trying to reassure him or correct his perceptions. He will eat food that his family brings, but when they leave meals for staff to serve him, he again complains of contamination. He has a history of Alzheimer's disease. Next, please. His family describes him as having always been overly cautious. His suspiciousness towards caregivers rather than Alzheimer's disease per se necessitated his move to long-term care. The family asks about the risks and benefits of initiating medical therapy to address his behavior. On examination, he has lost 1.8 kilograms in the last 60 days. BMI now is 20 kilograms per meter square. And physical and lab findings do not identify cause of the weight loss. So the question is, which of the following is true for this patient? A second-generation antipsychotic agent would double his mortality rate compared with placebo. B, citalopram at dose of 40 milligrams would be the best choice for his symptoms. C, control of symptoms with a second-generation antipsychotic agent would carry a higher risk of mortality than use of a first-generation agent. D, his symptoms justify use of a second-generation antipsychotic agent. So what do you think is the answer of this case? Yes, correct. The answer is D. Next slide, please. The symptoms justify the use of a second-generation antipsychotic. So we will go to the second case. A 70-year-old woman comes to the office to establish care because her previous physician retired. She is a retired nursing supervisor. Her main concern is that for the past year, neighbors have tried to get her to move by purposefully damaging the steps leading to her door. She does not know why her neighbors wish her harm. She produces photographs to illustrate the damage. The steps appears to be intact. Her daughter lives with her, but she has asked the daughter to leave because she believes that the daughter damaged the interior steps. The patient says that her daughter has her reasons, but she's secretive and can't be trusted. The patient is active in her church and manages her household and shoppings and finances without assistance. During the interview, the patient is alert and cautious. She is well dressed. She denies any history of abuse. Laboratory findings from 6 months ago confirm that she is in good health. She consents to cognitive assessment and mentioned that her previous physician also performed an assessment, the results of which were normal. Findings from today's assessment are normal also. So the question is, which of the following is the most likely diagnosis? First, mild frontotemporal neurocognitive disorder, dementia. B, delusional disorder. C, schizophreniform disorder. And D, paranoid personality disorder. So what do you think is the answer? Yes, correct. The right answer is B, because she has no signs of dementia, as she can manage her daily activities. There is no hallucinations, so she does not have schizophreniform disorder. So we go to our last case. A 76-year-old man comes to the office because he cannot sleep. He's a retired lawyer, devout and energetic. He serves as a legally appointed guardian, volunteering for the less fortunate. He has become increasingly tense, agitated, and irritable in the last few months. He has displayed volatility in the past. With considerable urging, he confesses that he is certain that the home care companions he hired to care for his court-appointed wards are about to publish pictures on YouTube of him fondling the caregivers. He feared that ensuing embarrassment will taint his family and ruin his relations with his church. Major depressive disorder, complicated by psychosis, is diagnosed. Therapy is initiated with low-dose antipsychotic and antidepressant agents. On follow-up, he seems to be more agitated than before treatment. So the question is, which one of the following other diagnosis most likely? A, delusional disorder. B, late-onset schizophrenia. C, major neurocognitive disorder with behavioral disturbance. And D, bipolar 1 disorder, manic episode. So what do you think the answer? The correct answer is D, because the patient has a lot of features of bipolar disorder. He cannot sleep, he's energetic, he's tense, agitated, and irritable. And he was given an antipsychotic antidepressant, and his condition has worsened after he has given them. A and C wrong, because there is no signs of dementia here, no signs of delusional disorders. And schizophrenia is also wrong, because he does not respond to the antipsychotics. So this is the end of our presentation of schizophrenia spectrum and other psychotic disorders. Thank you so much for listening. If you have any questions, we'll be happy to answer it. Thank you.
Thank you so much for the presenters for their informative presentation. Now we will move on to the second round of presentation. There will be 3 presenters, Doctors Chime, Moazir, and myself. And I will be starting off with the first part of polypharmacy in elderly population. I'm sorry, Dr. Abdulrahim, could you stop sharing your screen if you're done? Thank you so much. And then Dr. Moazir and Chime will cover the second and last part respectively. First of all, a little bit about myself. I am a US IMG CFMG certified, applying for IM residency this cycle. And now I'd like to start off by, I'll share my screen. I'll start off by talking about the polypharmacy in elderly. And I would like to start off by introducing polypharmacy in elderly. Just a second, please. The polypharmacy is the use of more than 5 medications, some of which may be clinically inappropriate. It's a growing concern in elderly population due to the risk of adverse effect and interactions. The objectives is to understand the scope, risk, and management strategies for polypharmacy in the elderly. In general, 25% of the overall population in the US experience polypharmacy in some manner. This prevalence increases to 50% for those aged 65 and older. Higher prevalence in individuals with comorbid conditions, for example, diabetic patients often have a higher risk compared to an age or sex-matched non-diabetic patients. There are many risk factors. Some of them include multiple chronic conditions like hypertension, diabetes, arthritis, etc., multiple healthcare provider, different specialists prescribing different medications. Some of them, they don't communicate with each other. Poor coordination of care, like lack of comprehensive medical reviews, and adverse drug reactions rise from 7% in those using 2 drugs to 50% in those using 5 drugs and 100% in those using more than 10 drugs. So as you can see, the risk of polypharmacy adverse effect increased tremendously with the number of drugs. Now we're going to talk about the adverse drug reaction. They might include drug-to-drug interaction, increased risk with multiple medication, drug-to-disease interaction, medication exacerbating existing condition, drug-to-food interactions, food altering drug effectiveness or causing side effects. Drug side effects, more medications mean higher risk of side effects, and multiple medication increase the risk of toxicity. The effect of polypharmacy on the quality of life. In ambulatory elderly, 35% experience adverse drug reaction, and of those, 29% require medical intervention, versus in nursing facilities, 2/3 of residents experience adverse drug reactions, and in extreme cases, 1 in 7 of these patients will require hospitalization. When it comes to hospital admissions, up to 30% of elderly admission involve adverse drug reactions linked to preventable geriatric syndromes. And the economic impact is very high because polypharmacy in elderly patients drives up healthcare costs through increased hospitalization, doctor's visits, management of adverse drug events. This financial burden is compounded by the expense of multiple medications and potential need for long-term care due to related complications like falls and cognitive decline. Over 10,600 deaths caused by adverse drug reactions annually, which brings up an annual cost of $85 billion. Pharmacokinetics and aging. Pharmacokinetics refers to how the body absorbs, distributes, metabolizes, and excretes drugs. Aging affects these processes by reducing both renal and hepatic function, altering drug metabolism, and changing body and muscle fat composition, leading to increased sensitivity and risk of adverse drug reaction in elderly patients. Now we're going to talk about absorption in the elderly. Age-related GI and skin changes generally have minor effects on drug absorption. Changes included decreased intestinal surface area, less efficient absorption, and increased gastric pH, which affect drug solubility. The presence of medical condition like vitamin B deficiency in atrophic gastritis, for example, and then interactions with other medication or food, as we mentioned before, can alter absorption as well. Now we're going to talk about distribution in the elderly. Age-related changes. First of all, we have decreased lean body weight and total body water to about 10 to 15%. We have increased body fat, 15 to 30%. We have a higher fat to water ratio, decreased plasma protein, especially albumin. Medical condition like heart failure, kidney disease can cause water retention or can cause a lot of problem with the distribution in the elderly. I have a question here. Drugs that are lipophilic tend to have a shorter half-life, shorter effects, longer effects, or none of the above. In order for us to answer this question, I have a key facts that we can talk about. First of all, the volume of distribution, which usually increases for lipophilic drugs, for example, sedatives, leading to longer half-lives. Metabolism, decreased capacity for phase 1 reaction while preserve phase 2 reaction. And finally, protein binding. Decreased plasma protein leads to a higher active free concentration in highly protein bound drugs. And that concludes my presentation or my participation, my part. And I would like to hand this part, the second part, sorry, to Dr. Moazir. Dr. Moazir, would you like me to continue sharing my screen or would you like to share yours?
I would like to share my screen.
Sure. I'll stop mine.
Okay. Thank you.
My pleasure.
Hello, everybody. My name is Moazir Abdelrahman. I'm a member from the Lyme 1 team. Brief about myself. I'm a medical graduate from Jazeera University, Sudan. I'm applying this year for internal medicine residency, and I'm SFMG certified. First of all, I would like to thank Dr. Nader for this great opportunity joining this great program. And also, I would like to thank Dr. Saja for giving me the chance to present today on behalf of our team member and for her effort moderating this presentation today. My part is I'm going to talk about metabolism in the elderly. There is a decline in the liver function, decreasing the liver mass and hepatic blood flow, reduce the metabolic capacity. Variability, highly variable effects with no reliable estimation algorithm. Minimal clinical impact, generally minimal clinical manifestation that usually you cannot see in the elderly patient. Drug interaction, there is concurrent drug use can alter metabolism in both directions. Estimation challenges, no formula to predict these effects accurately. Continuing the other metabolism and the elderly, drug effects on aging bodies. Aging alter how drugs affect the body. Lower doses needed. Older adults often require lower doses for the same effect due to two reasons. Receptor changes, the number of receptors, affinity, the post-receptor cellular effects may vary. Homeostatic mechanism, alter mechanism can change drug sensitivity, either increasing or decreasing. Now we'll talk about the Beers criteria, which is very crucial prescribing medication for elderly patients. These guidelines is about medication generally inappropriate for the elderly, or medication inappropriate for specific conditions like chronic diseases in some elderly patients. There is another criteria called stop-start criteria. The difference between the stop-start criteria and Beers criteria, which is also used to guide medication in older adults, that the stop-start criteria provide more detail, a rule-based approach for optimizing pharmacotherapy in this population. The stop mean screening tool for of older persons' potential inappropriate prescription, and the start mean screening tool to alert doctor to write treatments. This criteria usually used to help clinicians avoid common instances of potentially inappropriate prescribing and identify potential prescribing omissions. The 2002 criteria for potential inappropriate medication use in older adults, it's inappropriate. It's talking about the medication that's inappropriate for older adults due to high risk and minimal benefits. There is a long list, kind of boring list of medication that I'm gonna pick and choose and talk about. First drug is indomethacin, which is high risk of CNS adverse effect. Also the long-acting benzos, which can lead to sedation and fall risk. And this is very important, that fall risk is very important in this age group because it could lead to complications like fractures because of fragile bones or more serious complications like subdural hematoma. Other medication usually is talk about also the sedation risk, like anticholinergic drugs, antihistamines, barbiturates. And there is other medication that can lead to, more constipation, like ferrous sulfate, which is iron supplements. Continuing the list of medications, we have the NSAID, which could lead to risk of GI bleeding, renal issues. Nitrofurantoin, which is an antibiotic usually widely used for UTIs, can lead to renal impairment in this age group. And also there is the amiodarone, which can lead to QT interval issues. The 2002 criteria also is talking about considering diagnoses or conditions while you prescribing medication for elderly. This slide is usually talking about the condition that you have to ask your patient before prescribing such medication, like heart failure. You have to be caution prescribing disoberamide, which can lead to heart failure itself. Hypertension, also you have to be caution prescribing amphetamines, pseudoephedrine, diet pills. If the patient have gastric or duodenal ulcer, you have to be caution prescribing NSAID or aspirin more than 300. Seizure, epilepsy history, you have to be careful also prescribing medication like clozapine. If the patient have a history of blood clotting disorder, you have to be careful prescribing aspirin, NSAIDs. Bladder outflow obstruction, i.e. BPH, you have to be careful also prescribing anticholinergic, antihistamines. Stress incontinence, alpha blockers, anticholinergic, TCAs, all of it have a side effect that can lead to worsen the condition. Arrhythmia, you have to be careful if you're gonna prescribe TCAs, certain antipsychotics. Insomnia, you have to also be caution if you're gonna prescribe decongestant, theophylline, and MAOs inhibitors. Parkinson's disease, also you have to be careful and caution if you're gonna prescribe the antipsychotics especially because it's gonna be worse than the signs and symptoms of such patients. The 2002 criteria also, this is continuation of the conditions like cognitive impairment. You have to be, caution if the patient gonna take barbiturate, anticholinergic CNS stimulants. If the patient have depression, also long-term benzos is kind of contraindicated. Anorexia, malnutrition, also CNS stimulants, medication, syncope or false, short to intermediate acting benzos and TCAs should be prescribed with caution. Ciara, hyponatremia, SSRI, which is a very common medication used leading to this condition. Seizure disorder. Also, you have to be cautious if you're going to prescribe bupropion. Obesity, olanzapine is a very famous drug. Lead to metabolic problem like weight gain and hyperlipidemia. COPD, if the patient have this problem, you have to be cautious if you're going to prescribe beta blockers. Chronic constipation, also you have to be cautious if you're going to prescribe calcium channel blockers, especially the non-dehydropyridine receptor one like verapamil, and the anticholinergic and TCAs. That's conclude my part in this presentation. Now I will let Dr. Chime to continue the next part of this topic. Thank you.
Is it okay? Can you put up the slide for me?
It's okay, Dr. Chime, but Dr. Moazir, if you would like to continue sharing your screen, or would you like me to share my screen for Dr. Chime? I don't mind either way.
Sure, I could share my screen.
Sure, thank you so much.
No problem.
Hi, this is Chime. I'm going to talk about the rest of the slides for polypharmacy. So my slide is vitamin and herbal use in older adults. Prevalence, highly common among older adults to use vitamins and like different herbal supplements. 77% in Johnson and Wyandotte County community dwelling elderly use these supplements. Reporting issues are often not reported to physicians because they think, oh, it's supplement, I don't have to tell the doctor. So potential drug interactions are, we have warfarin and can interact with supplements like ginkgo biloba and vitamin E. So it can cause very serious complications. Key takeaway is we have to encourage the patients to inform their healthcare providers about all the vitamins and herbal supplements they use, so we can make sure that there's no adverse drug interactions and reactions. And the next slide. So herbal drug supplement and drug interactions in older adults. We have a couple supplements like ginkgo biloba that lots of people use for memory issues and all. It can interact with aspirin, warfarin, and adverse events. It can cause hemorrhage and hypertension. And St. John's wort, lots of people take this supplement for positive mood because it can help with depression. Interacts with protease inhibitors and warfarin again, and SSRIs. Adverse events are they can reduce drug levels. It can cause serotonin syndrome if you're taking SSRIs. Saw palmetto. Lots of people take saw palmetto for their prostate health. Adverse events, they can cause a headache and GI upset. And herbal supplements and drug interactions in older adults continued. Like ginseng, lots of South Asian people take it for energy and like build up their immune function. They can interact with warfarin, alcohol, and Mayo inhibitors. Adverse event they cause is they reduce INR and also increase alcohol clearance. Another supplement is yohimbine. I think lots of people take this to boost their performance. They can interact with tricyclic antidepressants, and many people can develop hypertension as adverse event. Senna, that lots of people know and take for laxative as laxative agents. They can interact with any other intestinal drugs that they take. And adverse event, they can cause reduced drug availability. Non-adherence to medications regimen. So non-adherence to medication regimens related to both physician and patient factors. It can be because of large number of medications that the patient is taking and any expensive medications that they're not able to afford, complex or frequently changing schedule. They're not able to understand when they're supposed to take, what they're supposed to take, any adverse reactions, confusion about brand name and trade name, difficult to open containers, because elderly populations, sometimes they find it very hard to open the bottles. Rectal, vaginal, and SQ modes of administration, they're like different and more complex, and limited patient understanding depending on their education. And geriatric prescribing principles. So the main principle is first you have to consider non-drug therapies. So we don't keep continuing to give a lot of medication to the patient, and then match drugs to specific diagnosis and try to give medications that will treat more than one condition. So if there's one medication that treats one condition of the patient, but there's another medication that targets like two conditions that patients have, we can choose that over the other one, and reduce medications whenever possible. Continuing, you have to avoid using a drug to treat side effects of another drug. So again, like you first start with like one drug and then you develop side effect, then you put another one, then that develops side effect, you put another one. So you keep continuing like adding a lot. So review medications regularly, at least every 3 months. I think this is really important. Avoid drugs with similar actions or same class. Clearly communicate with patient and caregivers about all the medications that they're taking, and consider cost of medications, because when you're taking multiple drugs, you end up spending a lot of money. Care is avoiding polypharmacy, caution and compliance. First, you have to understand the side effects. Know the side effect profiles of all the medications and identify the risk factors. Be aware of factors that increase
Excuse me, Dr. Iman. I'm sorry, Dr. Chime. Dr. Iman, could you please mute yourself? Thank you so much.
Thank you. Be aware of factors that increase the risk of adverse drug reactions. Assess the risk-benefit ratio. Carefully weigh the risk versus the benefits of each medication, and simplify dosing. So opt for once daily over twice daily dosing to enhance compliance. Check compliance. Regularly ask patients about their adherence to prescribed medications. If they're taking all the medications, how many times are they taking? These are important questions to ask. And adjust the dose. Start low and go slow and then titrate. I think this is really important. Give the minimum dose required, and consider the pharmacokinetics and pharmacodynamics of the medication, and review regimen regularly. Avoid automatic refills. Look for other sources of medications. We can go for like over-the-counter medications, and caution with multiple providers. Some providers, they don't know what other doctors have already given. So it's important to make sure all the providers are on the same page. Don't use medications to treat side effects. Again, the same point, side effects of other medications. Choose drugs to discontinue or substitute with safer medications. Polypharmacy, education is really important, both for the doctors as well as the patient and the caregivers. All medications, medicines, even over-the-counter have adverse effect, and you have to report all the products that you're taking, even herbal supplements and the other vitamins, and talk to your patient about potential adverse drug reactions that they can cause. Warn them of potential side effects and reports symptoms. Educate the family as well as the caregiver. Ask the pharmacist for help in identifying interactions. Assist your patient in making and updating their medication list. They can maintain personal medical record. Avoid seeing multiple physicians. Do not use medications from others. Personal health records, you can, it improves patient safety, reduce the risk of adverse drug reactions. Enhanced coordination involves multiple specialists in patient care. Smooth transition facilitates care transitions between independent living, hospital, nursing homes, and assisted living facilities. Emergency care aid, they can provide essential information during emergencies. And patient peace of mind offers reassurance and improves overall quality of life. Also, patient identifying information, we can look for doctors' contacts, on the caregiver's contacts, and past medical history and allergies that they have, and list of all the medications that they take, the dose, and reason why they're taking it, and whether it is newly prescribed. So these are the references that we took the slides from. I think that's the end of the polypharmacy. Thank you.
Thank you so much. That concludes the second presentation. Thank you so much for the presenters, and thank you all for listening. And now we're gonna start the third presentation. I would like to invite Dr. Rahma and her team to start their presentation. And again, please start sharing your screen. If not, I'll be more than happy to share mine.
Hello, everybody. My name is Dr. Rahma, and I am from Algeria, and I'll be applying to this internal medicine match this year, inshallah. I will be presenting bias in research with Dr. Sakshi. Okay, so our plan is: what is bias in research? Type of bias, impact of bias in research, historical example of research in bias, ethical application of research in bias, bias detecting and reports in research, the role of IA and machine learning in identifying bias. Finally, takeaway points and references. So what is bias in research? Bias is a deviation from the truth, which results in disordered results and wrong conclusions. Can occur at any phase of research, from data collection and data analysis to interpretation or publication. Can occur in quantitative and qualitative research. Results from the way participants are selected, how data is collected, or how results are prepared. Type of bias. First of all, we have information bias. Information bias arises when key study variables are inaccurately measured or classified. It originates from the approach that it is utilized to obtain or confirm study measurements. It occurs during the data collection step, common in research studies that involve self-reporting and retrospective data collection. Can result from poor interviewing techniques. Subtypes of information bias, we have, first of all, recall bias. Recall bias involves self-reporting. So self-reporting requires participant to respond to research question without her or his interference. It uses questionnaire, survey, or interviews. This problem frequently arises in observational studies designs. For instance, infrequent events will be remembered, like marrying or matching in a residency program for longer periods than frequent events, such as transportation or daily living chores. We have an example here for recall bias. Patients with specific illness may more readily recall and report past exposure to a potential risk factor than healthy individual, leading to skewed results. For instance, parents of patients with cancer maybe can remember what their child eats in a long period, but parents of a healthy children, they won't pay attention for this matter. The second type is observer bias. Observer bias is tendency of research participants to see what they expect or want to see, rather than what it is actually occurring. Can affect the results in observational or experimental studies, where subject judgment, such as assessing a medical image or measurements such as rounding blood pressure, leading up or down, is part of the data collection process. Leads to over or underestimation of true values, which in turn compromise the validity. An example of observer bias: research knows which participant received the treatment and expects it to reduce pain. They may subconsciously rate participants' pain level lower than they actually are, affecting the study's outcome. This can be avoided by using double-blinded and single-blinded research methods. The third type of information bias is performance bias. It happens when there is unequal care between study groups. Participants have knowledge of the planned intervention, therapy, or drug trial before it began. Studies about nutrition, exercise outcome, or surgical intervention are very susceptible to this type of bias. Hawthorne effect happen when subjects of an experimental study change or improve their behavior because they are aware of they are being studied. While John Henry effect is members of a control group are aware of they are being studied are being compared to the experimental group. This caused them to alter their behavior in an effort to compensate for their perceived disadvantage. An example of this in study testing an obesity drug, participants who know they are taking the drug may feel more confident about losing weight and, as a result, start eating healthier or exercising more than they normally would. This change in behavior can lead to performance bias affecting the study results. Blinding also can help prevent this type of bias. The fourth type is regression to the mean. Regression to the mean is statistical phenomenon that refer to the fact that extreme measurements naturally move closer to the average over time. Can affect research by making it seem like a treatment or intervention has an effect when it is just natural variation. An example of this, if a group of patients with very high blood pressure starts a new medication, their blood pressure may decrease simply because it was unusually high to begin with, not necessarily because the medication is effective. This can lead the researcher to wrongly conclude that the medication works. Using control groups and randomization to ensure that extreme values are equally distributed among groups, as well as long-term follow, may help avoid this type of bias. The second type of bias is interviewer bias. It occurs when the person conducting an interview influences the response of the interviewee in a way that affects the results. This can happen through leading question, tone of the voice, body language, like the way he reacts to response, or even the interviewer's personal characteristics like sex, sexual ethnicity, perceived attractiveness. Can lead to distorted data, reduced validity, and loss of reliability. An example of this type of bias is a very fit interviewer is conducting a survey on people's eating habits and exercise routine. Participants may feel reluctant to discuss their actual habits because they may feel judged or embarrassed. For example, they may underreport how much they eat or overstate how much they exercise to align more closely with what they think the fit interviewer would approve of. The ways to avoid this is blinding the interviewer of the study hypothesis, neutral environments, standardized questions, meaning questions that are asked in the same way to every participant. Interviewer training, train the interviewer to maintain neutrality and avoid leading question, and to be aware of their own bias, and finally, recording and reviewing the records. The other type of bias is publication bias. The results of research study influence whether they are published or not. Studies reporting results that are perceived as positive, statistically significant, or favoring the study hypothesis are more likely to be published due to publication bias. It can lead to misleading view of what works or is important in a field because we only see the success and not the failure or new results as wasting resource and time by replication studies. An example of this, a researcher conducts a study on a new drug and finds that it has no significant benefit compared to existing treatment. If this researcher feels intimidated by their peer or fears that the study's lack of positive results may harm their reputation or career perspective, they may choose to not publish this finding. It can be avoided by publishing all results. Record and publicly share research plan to prevent selective reporting. Encourage open access and transparency to allow others to verify and build on the research. The next bias is researcher bias. This happens when personal beliefs, preferences, and expectations influence research design or data collection process. Can be deliberate or unconscious. Pygmalion effect is a high expectation on a treatment leads to better performance and outcome. Can lead to overestimation of the effectiveness or overlook on the side effect. Can be avoided by blinding, follow a protocol, review by independent experts, peer review, and data transparency. Next, response bias. Response bias is a situation where respondents tend to provide inaccurate or false answers to self-reported questions, such as those asked on surveys or unstructured interviews. It occurs when respondents answer questions in a way that does not reflect their true feelings. This can happen for various reasons, such as the wording of the question, the context in which it's asked, or the desire of the respondent to please the interviewer. An example of this is a survey asking, "Do you occasionally indulge in tobacco use?" If a respondent doesn't realize this includes smoking, they may answer yes for chewing tobacco, even if they don't smoke. This leads to response bias due to unclear wording. The proper question should be, "Do you smoke cigarettes even occasionally?" To avoid this, neutral and clear language as well as ensuring anonymity can help. Next, selection bias. It arises from improper selection of a cohort that does not represent the greater population for which the study aims to be applicable, or inadequate randomization. Affect the generalizability of the finding, misleading interpretation, and flawed decision-making, as the research may only reflect the characteristic of the biased sample rather than the whole population. An example of this is selecting healthy participants to test the effectiveness of certain drug. We have multiple types of selection bias. Sampling bias. First, sampling bias. It happens when samples is selected in a way that it is not representative of the population you are analyzing. It affects external validity and generalizability. The second type is attrition bias. It happens when participants drop out of the study and those who remain differ significantly from those who leave. Volunteer bias, it results when the individual who volunteer to participate in a study differ from the general population, often being more motivated or interested. The next bias is survivorship bias. It occurs when you do not evaluate your data set in its entirety. For example, by only analyzing the patient who survived in a clinical trial. Non-response bias, it happens when certain participants choose not to respond or drop out after the study has started. This can skew the result in the non-respondents differ if the non-respondents differ from those who do not respond. Cognitive bias, it is a mental shortcut that leads us to make decision or judgment in a way that not always logical. It arises from our limited ability to process information objectively, can overlook important evidence, or draw flawed conclusions, ultimately affecting the validity and reliability of the research results. An example of this, a doctor has recently seen a COVID-19 case. He may start to overestimate the likelihood of COVID-19 as the cause of any respiratory illness, even when it could be a common flu. So be aware of cognitive bias and actively seek diverse perspective and objective evidence to guide decision. For cognitive bias, we have a lot of subtype like confirmation bias, anchoring bias, overconfidence bias, and availability bias. Now, my colleague, Dr. Sakshi, will continue the presentation. Do you want me to share the screen?
Hey, Dr. Rahma. Am I audible?
Yes.
Okay. Sure. Can you please continue the screen then?
Okay.
Okay. Thank you. Hello, everyone. So myself, Dr. Sakshi. Thank you, Dr. Nadi, for this opportunity. I'm continuing with the presentation. So for the further slides, the first question which I have for everyone is, why are we studying this topic? So, of course, other than the fact that we do get questions on this topic a lot on our USMLE exams. So, and I myself struggled with this topic for quite a long time. So the main part of this is because once you know what are the bias, importance of knowing the bias, a lot of us are interested in performing a lot of like research studies in future, or we are already, some of us are doing in it. So I think this is something which will greatly help to know this very critical information beforehand. And so I'll just continue with the further slides. So for the impact of bias on research outcomes, so the first thing is it will reduce the validity of study results. So as my colleague Dr. Rahma already spoke about this, so what is validity? Basically, it means that it is a measure to study how accurate your results are when you're trying to conduct a research. So to measure that accuracy, there are two types of validities, an internal validity and an external validity. So internal validity is something that the variables that we confront while performing a study. So we can try to control those measures while we in the setting of the research study. But when we try to apply this same study to an external real life setting, how accurately can we apply it and get those same results on a very continuous basis and constant way? So that is the difference between an internal and external validity. So when we try to study about the impact of bias, first thing is it will reduce the validity of the results that we obtain. Second is that it will skew the findings and lead to some incorrect conclusions. For example, again, if it is some pharma company trying to make some drug, and if we find if there is some bias going on, and if it goes through all the 4 stages of research studies and it goes into post-marketing surveillance and eventually in the market, that might cause a huge problem in the health sector, as we can imagine. So that's why we need to know at a regular basis how to control these factors. Thirdly, it will influence the generalizability of research outcome. Generalizability is just another term for external validities, as I mentioned you guys earlier. Fourth, it will lead to ineffective or harmful interventions being recommended. Fifth, it will undermine the reproducibility of studies. Sixth, it distorts the evidence base that informs policy and practice. And final point is it influences the direction of future research based on flawed data. Because in future, especially, yeah, it's okay. So especially like when we conduct systemic literature reviews, we try to take the support of the parent studies that are already being done. So if there is some bias going on in the parent studies, then definitely it's going to affect all the future studies coming up based on that. So yeah, you can go for the next slide. Thank you. So this is a very classic example of bias that happened in the year 1932. So this study is called as Tuskegee syphilis study. I believe it's a city in Alabama state. So in that study, what happened was they took around 600, it was a sample of 600 African-American male who were having a disease called syphilis. And unfortunately, none of them knew about it. So if that's okay, can I share a small video, YouTube video on my screen? That will help get a better idea.
Okay, I will stop sharing mine.
Yeah. Thank you. Is my screen visible?
Yes.
Okay. Oh, just a sec. Okay.
In 1932, the United States Public Health Service began a study of the effects of untreated syphilis on Black men in Macon County, Alabama. Participants' informed consent was not collected. The study initially involved 600 Black men, 399 with syphilis, 201 who did not have the disease. Researchers told the men they were being treated for bad blood, a local term used to describe several ailments, including syphilis, anemia, and fatigue. In exchange for taking part in the study, the men received free medical exams, free meals, and burial insurance. 4 decades later, on July 25, 1972, Associated Press reporter Gene Heller broke news about the study, prompting the U.S. Department of Health, Education, and Welfare to appoint an ad hoc panel to investigate. In October 1972, the panel advised stopping the study, and a month later, the study was ended. The panel concluded in their final report that the previous research on African Americans with syphilis was ethically unjustified. At the study's conclusion, only 74 of the original 600 men were still alive. 40 of their wives had been infected, and 19 of their children were born with congenital syphilis. The advisory panel's investigation led to compensation for the victims of the research and new protocols for the ethical treatment of human subjects of research. Voluntary informed consent for research subjects became the new standard and an explicit requirement for government-funded research. In 1997, President Clinton issued a formal presidential apology for the Tuskegee syphilis study. During its investigation, the panel collected a broad variety of historical documents and other papers. In 1973, a copy of the panel's working papers was deposited in the National Library of Medicine, NLM, located on the campus of the National Institutes of Health in Bethesda, Maryland. Through this research and related public education, made possible by the unique collection held by the NLM, as well as the National Archives, we acknowledge the participants in the Tuskegee study and the injustices they and their families suffered. We also acknowledge the work of the Tuskegee Syphilis Study Ad Hoc Advisory Panel to address the unethical actions of the study, which ushered in the protections for the rights of patients and which continue to evolve with new advances in science and medicine. The NLM collects and preserves collections such as that of the Tuskegee Study Ad Hoc Advisory Panel to improve transparency in research and to ensure that lessons of the past inform the present and future of biomedical research, healthcare, public health, and healthy behavior.
I hope the video and audio was good enough. Okay, yeah, I've stopped the screen. Okay. So I hope you guys just got an idea about this study. So the most important point to learn from this was informed consent was not a term established back then. And that was something that was taken, it was misused by the people who conducted the study in exchange for free meals and lunch to the poor families. And yeah, okay, we can go to the next one. Yeah, thank you. Okay, so again, ethical implications of research bias. So first is it violates the principle of integrity of research. Second, it undermines the importance of informed consent. Third, it misguides the policy and public health interventions. Fourth, it promotes inequality in the healthcare sector. Fifth, it misleads the funding allocations. Sixth, it results in legal and reputational consequences. And seven, it creates barriers to the scientific progress in our community of research. Okay. So how to overcome eventually all these problems that we are currently facing? So to detect these biases and reportings in research, we can do some mandatory conflict of interest disclosures, which I'm sure we all have encountered it while our publication work. Second, implement double-blinded studies to avoid the biases. Third, have a vigorous peer review process. Each journal has their own process to begin with. Fourth, register the clinical trials. Fifth, encourage replication studies to help get the same results on a constant basis, and that will help increase the power of our study as well. Seventh, transparency in the methodology and data. Eighth, independent data monitoring committee should be established, and like the one we have, International Review Board, IRB. And ninth, guidelines for reporting these research biases. Okay. And now, one very concerning aspect with the evidence of technology and AI, especially ChatGPT being very easily available. So it's been misused on a very large scale, including the field of research. But looking at technology, we can use it in two ways. Each coin has its two sides. So for AI, we can try using AI to detect an AI-generated paper. For example, we can use automated bias detection in the data sets of our publications. Second, we can predict the analytics for identifying these patterns. Third, we can use some machine learning models. There's a huge list of these models that are available to predict the publication biases. Fourth, the bias reduction in clinical decision support systems can be adhered to. Fifth, AI ethics and bias in algorithms. There are a lot of algorithms available as well. And sixth, AI tools for real-time bias monitoring. Okay. So as I mentioned earlier, it's a very important consideration when incorporating AI and machine learning tools into research. It's crucial to recognize that these technologies can also be biased due to the data they are trained on. This means that while AI can help identify and mitigate the bias, it can also introduce or perpetuate new biases if not managed carefully. Therefore, when using AI tools in research, it's essential to ensure that data is diverse and representative, regularly audit the models for fairness, and use fairness-aware algorithms to avoid amplifying any biases. This careful approach helps maintain the integrity of research findings and ensures more equitable outcomes. So some of the takeaway points. Bias in research, it can be minimized by knowing the different types of bias and their impact. With careful design, diversifying the sampling, and using correct AI tools, but also considering ethical part of it. This all will help us to guide how to address and manage all the biases that we encounter in today's research field. So a very famous quote, the demonstration of error marks an advanced stage of the science. All scientific inquiry is subject to an error, and it is far better to be aware of this, to study the sources in an attempt to reduce it, and to estimate the magnitude of such errors in our findings, than to be ignorant of the errors concealed in the data. By Herbert Hammond. Okay. Yeah. That's the end of our presentation. Thank you.
Thank you so much. Thank you so much for the presenters for their great presentation. And I agree with you, Dr. Sakshi. Biostatistics in general is very challenging subject for all of us medical graduates, especially with steps and everything. You did a great job. Thank you so much for your presentation.
Thank you.
And next on our agenda, we have the fourth presentation. I will be sharing my screen so Dr. Sara and her team can start presenting. Dr. Sara, are you ready?
Yes, I am.
Sure.
Assalamu alaikum, everyone. I'm Dr. Saja. I graduated from University of Khartoum in Sudan. And I will be presenting the physical activity and fitness in the community. It's basically a condensed explanation of the Framingham Heart Study. It's a very condensed study, but we did our best to simplified into the small points. Okay, so next slide.
Just a second, Dr. Sara, I'm having a little bit of technical issue.
No, it's okay. Take your time.
Are you able to see the screen now?
Yes.
Oh, perfect.
Okay. So I'm sorry about that. Hold on. Okay, I apologize for that. Okay, so as an introduction, physical activity is widely recognized in its role in reducing cardiovascular disease risk and improving overall longevity. So we have information about how physical activity affects the heart, the brain, the muscles, the bone, the cholesterol, diabetes, all of that. But there was a research gap that did not pertain to how physical activity links to, the different components of physical activity, how they link to the cardiorespiratory fitness. So the physical activity was explained as steps per day, moderate vigorous physical activity, and a sedentary lifestyle. And they compared these three categories on how they affect the cardiorespiratory fitness. So the objective was to provide a detailed examination of how different types of physical activity relate to multiple dimensions of cardiorespiratory fitness, and also to explore how changes in physical activity over time impacted fitness levels in various demographic groups. Next, please. Okay, so what the study went about was how it was a longitudinal cohort study that began in 1948 with 5,209 participants in Framingham, Massachusetts. The study aimed to understand the causes of heart disease by following a group over time. The Framingham cohort, a joint project between the National Heart, Lung, and Blood Institute and Boston University, has expanded over time, now including 3 generations of participants and 2 minority cohorts. So they basically followed a big group over time, and no, it's okay. They followed a big group over time, and next. They followed a big group over time to find the correlation between the different types of physical activity and the cardiorespiratory fitness. So the research objectives were divided into a primary aim, and then to speak in more detail, into a secondary aim. So the primary aim was the study seeks to qualify the relationship between various physical activity measures, for example, steps per day, moderate vigorous physical activity, and sedentary lifestyle, and different domains of cardiorespiratory fitness, particularly focusing on peak oxygen uptake, which is going to be a very important point, so please bear that in mind, and the oxygen uptake kinetics during different phases of exercise, so during the initiation of the exercise, during the peak of the exercise, and during the recovery. The secondary aim was to assess how these relationships vary across age, sex, BMI, and cardiovascular risk categories, and to evaluate the effect of physical activity changes over nearly a decade on fitness levels, providing insight into the longitudinal impact of physical activity on health. So this basically gives us a more comprehensive view on how physical activity affects the cardiorespiratory fitness, rather than, for example, doing a cross-sectional study. So the population included 2,070 participants from the Framingham Heart Study, predominantly middle-aged, with a balanced representation of men and women to eliminate any bias. And I will pass the mic to Dr. Loay, who's going to explain the next section, and then we'll circle back to me. Thank you.
Hi, everyone. Can you hear me, please?
Yes.
Yeah. First, I would like to thank Dr. Nader Abdelrahman for giving us, this opportunity actually to share our presentation. My name is Loay Mohammed. I'm a ECFMG certified, and I will continue on our presentation on the Framingham Heart Study, actually to study the role of the physical activity actually and its impact on our cardiopulmonary fitness.
Dr. Loay, I'm sorry to interrupt. Would you like me to continue sharing my screen, or would you like?
Yeah,
okay,
yeah,
no
it's
problem.
okay. Yeah.
We'll do that definitely.
Yeah. Can you? Yes. As we mentioned actually earlier that the Framingham Heart Study actually studied around 2,070 patients, but this number of patients reduced to 1,720 patients in two setups of exams. As Dr. Sara actually mentioned earlier that this study is a long cohort study started 4 decades ago, but our study actually examined the patients in two main sets of times. The first one actually is at the first decade of the second millennium, around 2006. And the second exam, which is exam 3, actually occurred in a decade later. So the duration of this cohort study is around 8 years. As you can see here in this figure, actually, the study raises two main questions. The first question is how to measure a routine physical activity relate to physical measures of cardiopulmonary fitness. And the second question is, are changes in physical activity over time linked to higher cardio respiratory fitness? Next, please. So the study design in general is use data from the Framingham Heart Study, the main one, particularly focusing on the generation 3, Omni generation 2, as I mentioned, one in the first decade of the second millennium, and the second one on the second decade. Participants underwent maximum efforts of cardiopulmonary exercise to measure fitness and wore accelerometers for 1 week to objective record their physical activity levels. That's why the number of participants, reduced from 2,000 to 1,700 because of this thing. So the data collection for the cardiopulmonary exam test measured the peak oxygen uptake, which reflects the cardiorespiratory fitness, which is a key indicator of how well the body can transport and use oxygen during exercise. And this is the VO2 is going to continue with us actually because it's the main measure of the cardiorespiratory fitness. So the accelerometer, as I mentioned, is capture the physical activity data, including the sedentary time, the steps per day, and the moderate vigorous physical activity. So we have 3 types of physical activity, which we are going to observe actually during those 8 years of the cohort study. So these measures were recorded both at the time of the cardiopulmonary examination test and for, as I mentioned, for almost 8 years. So the statistical analysis which was multivariable linear regression models were used to assess the relationships between physical activity measures and fitness outcomes. So adjustments were made for clinical risk factors such as age, sex, body mass index, smoking status, hypertension, and diabetes. So most of the risk factors that we are known about. The study also considers seasonality and geographical locations to account for potential variation in physical activity. So the two main points here are the maximum effort for cardiopulmonary exercise testing and objective physical activity measures, as I mentioned, for the 3 components of physical activity via accelerometers, worn for 1 week. And so the population, as I mentioned, were around 2,070 Framingham study participants. They were mostly middle-aged men and women. And we measured the oxygen uptake for those people. The second component is we adjusted for the clinical risk factors, as we mentioned, the physical components, plus the risk factors, the other risk factors like diabetes, like hypertension, the body mass index, to measure and observe the oxygen uptake during exercise. So The components of the uptake were during initiation first, then the second step was on the moderate level of physical exercise, then the third level was at the peak of the exercise, and the fourth component was at the recovery time. Next, please. So this is a continuity of the methods here. The maximum effort of cardiopulmonary exercise testing and the objective of the physical examination activity measures for the three components where the accelerometer, as we mentioned earlier, worn for 1 week, concurrent with the cardiopulmonary examination test for 8 years. And these are adjusted for clinical risk factors, as we mentioned earlier. Yeah, next, please. So the study sample, yeah, continue. Actually, this is like a repetitive slide. I'm sorry for that. Yeah, continue. To the next slide. Yes. So the different types of physical examination were the components, as we mentioned, for the 2000. And the accelerometer were worn, as we mentioned, for 1 week for the three components. They're changed over nearly for a decade. The large sample size permitted assessment of how various combination of sedentary life, steps, and the moderate vigorous physical activity were related to the cardiorespiratory fitness, as well as enabling examination of how relation of the physical activity and fitness measures varied across the age, sex, and cardiovascular risk status. Next, please. So when we break down the cardiopulmonary examination test, it's 4 parts. The first part was the initiation, was almost for 2 minutes of rest. Then the second step is like the initial one is for 3 minutes of unload free will exercise. And the third component is a maximum incremental ramp for 15 to 25 minutes. Then the final stage is the recovery stage, which includes about 3 minutes of unloaded cycling, followed by 1 minute of rest. Next, please. This table actually shows that the major measure of the cardiopulmonary examination test depends on the measure of the oxygen uptake, the peak oxygen uptake during exercise. And it shows us actually the initiation of moderate and the initiation moderate, and the physical significance and the measurement, methodology. You can review this later on in the study. It can be more clear. Next, please. The accelerometer assessment of physical activity, participants attending the exam 2 and exam 3, as I mentioned, the first decade and the second decade, were asked to wear an omnidirectional accelerometer for all hours except when bathing for 8 days on a belt worn around the waist. Next, please. Given difficult in discriminating sleep from waking wear time, participants at exam 3 were asked to remove the device during sleep. So these are the factors, like the covariate assertments actually were adjusted later on, like for the smoking, diabetes, the prevalent cardiovascular disease, and the 10 years of atherosclerotic cardiovascular disease. So smoking here actually was reported as current smokers, former smokers, and never smokers, diabetic patients, either they're diabetic or they're taking anti-hyperglycemic medications, or patients with history of cardiovascular disease like myocardial infarction, stroke, heart failure, and also the 10 years atherosclerotic cardiovascular disease risk assessment. Next, please. So after reviewing the variable distributions for the normality, the peak VO2 at the ventilatory anaerobic threshold and the moderate vigorous physical activity were naturally logarithmically transformed. And the VO2 recovery delay was squared root transformed prior to analysis to reduce the skewness of these variables. All CPET and the physical activity variables were mean centered and standardized prior to analysis. So they evaluated the cross-sectional association of the CPET variables with the physical activity measures at exam 3 using multivariable linear regression models adjusted for age, sex, cohort, season of activity, monitor wear, location average, minutes of activity monitor wear, 4 steps, and MVPA, body mass index, resting systolic blood pressure, hypertension, medication use, smoking, diabetes, and prevalent cardiovascular disease. Next, please. So they studied how clinical factors influence the connection between physical activity and exercise variables like age, sex, body mass index, and cardiovascular status, and also assessed nonlinear relationship between physical activity measures and peak VO2 visually. And also we found that there is linear regression models were used to analyze the relationship between cardiorespiratory fitness domains and change in physical activity from exam 2 to exam 3. And also the covariates include baseline physical activity exam, interval, and seasonal differences. Next, please. So the results here actually are quite striking, actually, that both types of physical activity, like the steps, the regular steps, and the moderate vigorous physical activity, they show increase in the peak oxygen consumption, while the green one is the sedentary time. Actually, we see that there is reduced reduced peak oxygen consumption. Next, please. So the associations of physical activity measures with multi-domain measures of cardiorespiratory fitness. Physical activity measures showed modest linear relationship with peak VO2 adjusted for risk factors. Significant associations were found with different fitness domains. Various physical activity measures were linked to different exercise components. FDR less than 5% was found. So the higher moderate vigorous physical activity was more strongly linked to fitness responses than sedentary behavior or step count. A 1 standard deviation increase in moderate vigorous physical activity was associated with a 5% higher peak VO2 and 96% more MVPA. So around 3,458 additional steps and 182 fewer minutes of sedentary time daily. So these are the recommendations, actually, that when we increase the physical activity and reduce the sedentary time of patients, actually improve the cardiopulmonary fitness. Yeah, next, please. Continue. Higher peak VO2 values were observed in groups with greater than average, as we mentioned in the steps, regular steps, and the moderate vigorous physical activity and low sedentary time. Individuals with low steps per day or moderate vigorous physical activity displayed estimated peak VO2 values below the mean, regardless of whether they had higher or low SED. Finally, to assess whether the association of physical activity and fitness measures differed across categories of clinical variables, we evaluated for effect modification by age, sex, body mass index, prevalent cardiovascular disease or diabetes, and cardiovascular disease risk. Despite several significant interactions, the key findings were largely consistent across clinical categories. The study also observed the evidence of effect of modification by sex, association of SED and peak VO2, such that 1 standard deviation higher sedentary was associated with a large decrement in the observed peak VO2 in women compared with men. Next, please. In this figure, actually, it shows that the peak VO2 is highly observed in the high steps with high sedentary high steps, and the high sedentary high moderate compared to the moderate vigorous physical activity, and the last one is the high moderate physical activity and higher steps, actually. Next, please. So the other component of the study is the association of changes in physical activity measures over time and cardiorespiratory fitness. And all these statistics evaluated the association of changes in physical activity measures over a median interval as almost 8 years. And in 1,700 patients, almost, individuals who attended both exams 2 and 3 and had complete accelerometry and CPET measures. So the changes in the physical activity measures were not associated with heart rate or blood pressure responses during exercise, but were reflected in the metrics of the VO2 kinetics in different domains of exercise. So increases in average steps or moderate vigorous physical activity and reduction in the sedentary lifestyle between the 2 exam cycles were related to favorable measures of each exercise domain, with the largest effect size observed for the moderate vigorous physical activity. So overall, an increase of 17 minutes of moderate vigorous activity per day, or more than 4,000 steps per day for almost 54 minutes at 80 steps per minute, or reduction of 249 minutes of sedentary life per day between the 2 exam cycles corresponded to a 5% higher peak of oxygen consumption. Next, please. So lastly, we estimated the marginal mean log peak of the oxygen consumption for individuals with physical activity values above or below the approximate sample mean at 2 exam cycles. Continue, please. This figure also shows the relationship of the standardized log peak of the VO2. As we can see that the high relation of positive effect actually is showed for the high steps per day and in exam 2 and 3, and the second one is the high MVPA exam 2 and the high MVPA exam 3. Next, please. So there was a stepwise increase in the peak VO2 from individuals with low steps MVPA or higher SED at both exam 2 and 3 to high steps MVPA or low SED at 1 exam, to high steps MVPA or low SED at both exam cycles. Notably, peak VO2 was similar in the groups with high steps MVPA or low SED at one of the exam cycles, regardless of whether it was the current exam when the CPAD was performed, exam 3, or the previous exam. Next. This table actually studies the association of change in physical activity measures from exam 2 and 3 with cardiopulmonary exercise testing fitness at exam 3. All these measures actually are for the 3 components, for the sedentary time, for steps, and for the MVPA. Next, please. So Dr. Sara can continue from here for the discussion.
Okay, so to wrap up the presentation, the key findings between the physical activity and the cardiorespiratory fitness were highlighted in the following points: that there was a strong association with peak oxygen consumption, the primary measure of cardiorespiratory fitness. An increase in MVPA was linked to significant improvement in oxygen consumption levels. Steps per day also contributed to improved fitness, but not as much as the moderate vigorous physical activity. Reduction in sedentary time were similarly beneficial, but also had a smaller effect compared to the MVPA. So the study found that increases in steps per day and reduction in sedentary lifestyle both contributed positively to fitness, but the impact was most notable with moderate vigorous physical activity. These associations were consistent across different demographic groups, indicating that the benefits of physical activity on fitness are broadly applicable. Okay, so a 5% increase in peak oxygen consumption was associated with 22 additional minutes of moderate vigorous exercise per day. 3,458 more steps per day, so approximately 40 minutes of walking, and 182 fewer minutes of sedentary lifestyle per day. Next. In regard to the cross-sectional associations, the peak oxygen consumption and the physical activity, there was a strong correlation between physical activity and peak oxygen consumption, as we mentioned before. If we were to just simply just put into bullet points what each one contributed, the MVPA is the most significant impact on fitness the most significant impact on fitness was seen with MVPA. Higher levels of MVPA corresponded to notable improvement in peak oxygen consumption across different phases of exercise. Steps per day, increasing daily steps also positively affected the oxygen consumption, although the effect was less pronounced than MVPA. Sedentary time, higher SED was associated with lower oxygen consumption, underscoring the negative impact of prolonged inactivity. In regards to the fitness domains, physical activity measures were linked to various fitness domains, including exercise initiation, moderate level exercise, peak exercise, and recovery. The complementary effects of physical activity is that physical activity measures were found to be complementary, meaning that a combination of higher, moderate, vigorous physical activity and steps, along with lower SED, yielded the best cardiorespiratory fitness outcome. Next. Now, considering the longitudinal change in physical activity, the study evaluated changes in physical activity over nearly 8 years, as we've mentioned before, and their effect on fitness. So positive physical activity changes, increases in MVPA or steps per day, and reduction in SED over time were linked to improved fitness metrics. The most substantial gains in oxygen consumption are associated with MVPA. Quantitative findings were already mentioned before a few slides back. Fitness consistency, participants who maintained high MVPA or steps per day across both assessment periods had significantly better fitness compared to those with lower physical activity levels. Even participants who improved their physical activity in just one of the 2 periods saw notable fitness benefits. Next. So in regard to the public health impact, the findings underscore the importance of regular physical activity, particularly moderate vigorous physical activity, in improving and maintaining cardiorespiratory fitness. Interventions that encourage even modest increases in MVPA can have significant long-term health benefits. Targeted physical activity recommendations are that the study suggests that the PA guidelines should emphasize increasing MVPA, reducing SED, and incorporating more daily steps, particularly for individuals at higher cardiovascular risks. So make sure to get your steps in. Demographic considerations, the benefits of PA were consistent across various demographic groups, meaning that the physical activity interventions can be broadly applied across different populations. So basically, in conclusion, what we wrote here was like a condensed, a simplified, or a summarized bullet points of what myself and Dr. Loay spoke about. You can go back to them in your free time, and if you have any questions, we'll be more than happy to answer them. Thank you so much for your time, and we hope that this was a beneficial presentation to you.
Thank you so much, Dr. Sara and Loay, for their presentation. It was very informative. Now, for the final round of today's presentation, I'll be presenting with Dr. Moazir, and I'll be covering the first half of the presentation while Dr. Moazir will finalize the last part. I'll start by sharing my screen. Sorry, I need to stop first. I'm sorry, I'm just having a little bit of technical issues. Just give me a were you able to see the screen?
Yes.
Oh, perfect. So the effect of psilocybin on hospice elderly patients by enhancing quality of life through psychedelic assisted therapy. We start by asking about what is psilocybin. Psilocybin is found in magic mushrooms, which has been used in Mesoamerican culture like the Aztecs for thousands of years for religious and healing rituals. Discovered by the Western scientists in the 1950s and isolated by Albert Hofmann in the 1958 when he accidentally ingested a little bit of it, I think, on his skin while he was working on it and isolating it. And he experienced altered level of consciousness, and it gained a lot of popularity in the 60s, counterculture, leading to its criminalization at that time in the 60s when the war on drugs by President Reagan was there, and then it affected the research and further research on the psilocybin. Early research highlighted its potential for treating mental health disorders, but legal restriction, unfortunately, as I mentioned before, halted its progress. Research fortunately resumed in the early 2000s at institutions like Johns Hopkins and Imperial College of London, revealing significant therapeutic benefits. Some clinical applications. Psilocybin effectively reduces symptoms of depression, and not only regular depression, it's the treatment-resistant depression, anxiety, PTSD, and shows a promise in treating substance use disorders like alcohol and tobacco addiction. The mechanism of action, psilocybin is a prodrug, primarily targeted the serotonin receptors in the brain, specifically the one 5-HT2A, altering perception, mood, cognition, and also promotes neuroplasticity, which helping the brain form new neural connection, which underlies its therapeutic effects and facilitates emotional processing and acceptance. The role of psilocybin in palliative care is basically addressing terminal distress, anxiety, and depression, and the goal is to improve emotional well-being by enhancing the quality of life and providing existential relief. Imagine you receive a diagnosis, or we receive, a terminal diagnosis, and as of we all know, being in hospice is definitely you have a diagnosis of 6 months. So imagine the anxiety and depression that a patient can feel when he receives that diagnosis. So now we're going to talk about the medicinal benefit in hospice patient that can help with their anxiety and depression by easing end-of-life anxiety. Psilocybin has shown promise in reducing anxiety and depression in terminally ill patients, including elderly hospice patients. Studies indicate that a single dose, imagine just single dose, can lead to significant and sustained improvement in mood, anxiety, providing relief from existential distress, often experienced at the end of life. When it comes to pain management, while primarily studied for its psychological benefits, psilocybin effects on perception and cognition may also help in pain management by altering patients' experience of pain and reducing the emotional distress associated with chronic pain. And when it comes to improved quality of life, enhancing well-being, psilocybin-assisted therapy can lead to enhanced well-being and improved quality of life for elderly hospice patients by fostering a sense of peace, acceptance, connection. It can help patients and find meanings and closure in their unfortunately remaining short time. That concludes my part of this presentation. Now I will hand out the rest of the presentation to Dr. Moazir. Dr. Moazir, would you like me to share my screen, to continue sharing my screen, or would you like to share yours?
Yeah, I would like you to share your screen.
Sure.
Thank you. Yeah, so my name is Moazir Abdelrahman. I'm going to present the last part of psilocybin effects and on hospice care. First, I'm going to talk about the effects of on the quality of life, psychological benefits, emotional benefits, social benefits, like alleviation of existential distress, enhanced mood and reduced anxiety, increased sense of peace, acceptance, and well-being. Social benefits include the improved interaction with family and caregivers. Neurobiological effect include changes in brain activity, enhanced emotional processing. Psychological impact altered the perception of self and life, improved emotional resilience. Spiritual and consistent relief, greater acceptance and peace with end-of-life issues. Next slide, please. Psilocybin have side effects and a safety regulation. Common side effects is nausea, transient anxiety, altered perception. The safety profile is generally safe in controlled setting, important to consider individual health conditions. There is also ethical consideration. Informed consent, of course, ensuring patients are fully informed about side effects and safety profile. Therapeutic setting, importance of professional guidance and support. Legal status, which varies between state to state, and law and regulation. Next slide. There is a current research and application, which include clinical trials. Of course, clinical trials show psilocybin safety and efficacy in treating end-of-life anxiety and depression, conducted in controlled environment with professional guidance. Regularity status, although psilocybin remains a Schedule I substance in many countries, there is a magnificent efforts to reclassify it for medical use. Some regions have decriminalized it, and the FDA has granted it breakthrough therapy status for major depressive disorder. Practical consideration in hospice care settings and support, control environment, as we said, administration of psilocybin in a controlled, supportive environment is crucial. Professional supervision ensures that patients receive the emotional and psychological support they need during their experience, something like chemotherapy sessions. Integration with existing therapies. Holistic approach. Psilocybin therapy should be integrated with other palliative care practices, including pain management, counseling, and spiritual care to provide comprehensive support for elderly hospice patients. At the end, the conclusion is psilocybin offers promising benefits for elderly hospice patients, particularly in alleviating end-of-life anxiety, depression, and pain. As research continues and regulatory landscapes evolve, psilocybin could become a valuable tool in enhancing the quality of life of terminally ill patients, helping them find peace and meaning in their final days. And that concludes the last part of our presentation. Thank you so much for listening and watching.
Thank you so much, Dr. Moazir, for the presentation, and I would like to thank all of the presenters for their hard work and their effort. And I will hand out to the mic to Dr. Nader if he would like to talk about any project update or if he has anything else to share with us. Thank you so much, all.
Dr. Saja and all the presenters. These are great presentations. Thank you so much for your great work. So the last part is project updates. Any updates from the fellows? I know some of you are working on different research projects. Go ahead, Dr. Randa.
Assalamu alaikum. Hello, Dr. Nadir. How are you?
Good, thanks.
Thank you. Hello, everyone. And very thank you, Dr. Nadir, for this great opportunity. And thank you all the presenters today for these informative and amazing presentations. My name is Randa Hassan, and I am a medical graduate from Kordofan University in Sudan, and I'm applying for residency program this season 2025. And I'm very glad to be part of this research fellowship program. Dr. Nadir, I want to update you regarding our project, which is a mobile application for diabetic patients to help them to regulate their carbohydrate content in their diet. So if there is chance to share my screen.
Yes.
So I can share with it so far.
Go ahead.
Okay. Are you able to see my?
Yes.
Okay. Yeah. Okay, I will share with you the modular companion, which we use it for test all the steps we did in the project. So now I will start connect the companion, and you can see that on live. Yes. Yes, now it's loading. Okay, this is the first screen, is the splash screen. Our app is named Smart Diabetes Control. Splash screen just is take a second and opens the login automatically. So on login screen, we have, as you see, the username, password, and we can try that. If you want to enter the username, this. If I put the username and the password randomly, like this, and the username like this randomly and login, it say okay, that if I just write my name and the username just for test, and let me there's open the next screen, which is the main screen. Okay. As we said, our app is Smart Diabetes Control, and yes, I put this text to temporary, just to give a definition about our app. This app was designed to help diabetic patients to regulate sugar content in their diet and to track their blood glucose, medication, and other. Just to make some idea for the patient. Here is the menu. From the menu, we have my profile, diet, tracking list, graphs and charts, educational topics, community, download and share, and setting. Okay, we'll start with my profile. If I press in my profile, give me the name, date of birth. You can tell here. And the date of birth, we can choose date of birth, and also the email, glucose, and add blood sugar, systolic and diastolic, and also medication. We can save or share this one. We'll go to the in and open the diet. For the diet, we have we can do the date and time, or something like this, and we have a list from U.S. Department of Agriculture that there is extensive list that show types of food and the values for carbohydrates, vitamins, and other. Yes, we're struggling with this steps. It's a spreadsheet, and we put it in Excel and also in Google Sheet, and we tried to connect it to the scheduler, but still we didn't fix the problem. So we need help with this one. If you have any advice. Also our plan, besides this, we can do a scan for barcode, or can take just picture from the meal. Like this, calories, the carbohydrate, fat, vitamins. Go back again. The tracking list. We have tracking list of glucose, blood pressure, heart rate, oxygen, temperature, weight, BMI, height, hemoglobin A1C, diet, exercise, insulin, medication, and there is not. Some fellows, they working on this task. They did some, but still we have a problem in to separate the page. They search about it. Anyone, he can help us also. He can help us. I will go back. And see that we have charts and graphs. There one fellow, he working on this, but still he didn't finish it. So we not want to make the charts to monitor the progress in the tracking list. Also here we have educational topics like important question to ask your doctor. Type 1, 2, nutrition, fitness, treatment, insulin resistance, complication, follow-up. Patient you can have idea about this condition, like this one. We have some question here. Patient are asked doctor. You will be oriented and about this condition. Again, I go back. And this the medication about the type 1 versus type 2 diabetes. Doctors work on this and provide nutrition also. Follow up. Yes, one topic, still one group they working on it. The other was done. Now I will go back again. And we have also community, so the patients communicate with others, they share their information, some question. And also we have download and share their information with their doctors or some else they want to share with you. Those also some fellows they work on it still. The last one is the setting, and this will be the final task. Skill is still and that all what I want to share with you, Dr. Nadir. And well, that's what we so far, and we need your advice. If you have any suggestions, any comments, and that's all. Thank you so much.
Thank you so much, Brenda, for this great tutorial or demo. This is great, excellent work, and the project is going well so far, so good. Wonderful. Any comments from the fellows? If you have comments, go ahead. I think so far so good. So regarding the improvement or the handling the task that you face, we can work on that. Maybe together I can share some tips to solve some of the issues. Maybe we can talk about that if you have time after the meeting.
Okay, sure.
Sounds good.
So much, really appreciate it.
You're welcome. Yeah, anytime. Any other questions or comments or suggestions for Brenda and her team? So what I suggest to you, Brenda, I know you have a big team. It seems like you designed or you already started with dividing the task between the members, the fellows. So what I think might be a good opportunity for new fellows or fellows that are interested in participating with you, but they don't have the technical abilities or the know how to work with the programming and so forth. So what I think, you can open the floor to the other fellows to join you and divide these new fellows into a couple of teams. One team will be working on the advertisement or the social media aspect. So you want to see if there are people who are good with building like in their community or their LinkedIn or Facebook page, or they can develop a new page for this project per se, and then they can put some advertisement that's, for example, expected in late August or in September, this new app. The other team or people can work on getting some WhatsApp group so that they can spread the word. And the third part, maybe a group of fellows who will test the app when it's uploaded to the store. I take it is going for Google Store for step one. So if you have a group of fellows who are ready from day one, they can test the app, download and see in different devices how that's working. Maybe this will be a group that will help you also when the app is uploaded to the web or to the store, because we really need the app to hit the road from day one. So we need some people who will test the app, who will spread the word about the app, who will get other physicians or family members or patients with diabetes to download and test the app and give us feedback. So if you plan ahead, by the time you are ready to publish it, it will be a good first step when you hit the store. This is my suggestion. Thank you.
Yeah, that's great, Dr. Nadir. Thank you so much.
You're welcome. And one more thing for everyone, if you are interested in participating in the project, maybe you can contact Brenda, and one of the fellow or couple of the fellows in your team, maybe they can create a short introduction video about the steps that are taken to build this app. So, for example, we use this modular we built from different websites or whatever. Just a brief 3 minutes or so, 5 minutes about how you divided the teams. And so by the time, if you get an interview, everyone who is involved in the project will talk about the project from A to Z. Their part might be just a simple one, focusing on part of the project, but they know the steps, the whole big picture. So that also might be a suggestion. Thank you.
Yes, of course, the door open for everyone who is interested.
Great.
To us.
Thank you.
And just anyone have any idea about how to connect the spreadsheet? This is most part that we're struggling on it. We want to connect the spreadsheet from the Excel or from the Google Sheet to the Modular. So it'd be easy. If we didn't do that, the final option, I think we can do it manually. But that take time and need some effort.
Maybe we can talk about this in.
Okay, thank you.
Thank you. And Dr. Sara, you want to?
Sorry to interrupt.
No.
Tirarenda, this is a very creative initiative. I would be interested to work with you if you would post or maybe share with us a I'm sure other fellows are interested. Share a way for us to contact you, email, WhatsApp, or anything you're comfortable with. Thank you.
Okay, of course, I will share the link, the telegeriatric research WhatsApp group. Sara.
Oh, okay, thank you.
Sounds good. Thank you, everyone. Any other questions, comments before we finish the meeting?
Sorry, just to make sure I understand, are you going to share the WhatsApp link in here, or are you going to share a link in the group?
I will share it on the telegeriatric WhatsApp group.
Because I'm not on that group, so how can I be on
Can
that?
anyone add the WhatsApp alert group in the chat?
Yes,
The
if someone can please post the link to the group on the Zoom chat, that would be beneficial. Thank you.
Okay, we'll try to send it here.
In the meantime, and Alina, go ahead.
Hi, Dr. Nadir. I'm a new participant, so I'm sorry if my question isn't, very smart. I'm sorry. And thank you. I'm glad to be a part of this program. My question is regarding projects. I can see that there is many projects in the app, and my question actually is regarding when do this project start actually, and is the leader should contact with us, because I'm a new one here, so I'm very sorry.
First of all, you are welcome here, and thank you for joining. So the question about the project. So the app has a lot of projects. What you can do, you can select one of them and see who is in that project. If there are some, you can, or some of these fellows together can identify a leader for that project, and then that leader will divide the task between you guys. Each one will have a part, and then you can finish that project together. So if you have specific questions, in the app itself, we have senior group and we have the juniors. So you can ask some of the seniors in your team. Let's say you are in pink team. There are some seniors in pink team. You can try to connect with them, or in the WhatsApp in general, in the WhatsApp that was shared. You can say, for example, I'm new, I'm interested in this project, and we have this group of fellows interested in starting the project. So you will identify what method and what the steps. If you know how to, go ahead. If you have questions, some of the seniors here will help you. So Nada, share the link for the WhatsApp group in the chat if you want to add yourself.
Okay, thank you so much. Thank you so much for help.
Welcome. Any other questions, comments, suggestions?
I have a question. I'm also new, like Dr. Alina, so I'm a little bit confused. So I'm using Apple devices, and for some reason I can't download the app on my phone or on my device. So I'm using the browser. I don't see a section for the projects that you mentioned. So I don't know, maybe I'm not looking in the right place, or it's not visible for me, but I really can't see what the available projects are.
Yeah, that's absolutely fine. I'm gonna add some. It's just a technical back end thing, but usually what you're gonna see here the home, then there are some question about requesting a letter of recommendation. In the middle, you will have some projects. If you hit on it, it will start listing all the available projects. And you can add new project if you have some ideas. And if you want to join any of these, you can hit any and then contact the people who are in this group, see who will be the leader for that project. If you have time, you can be the leader and ask them to help you. And so it's going to be somewhere here. It might be just an activation process. I'm going to give you the access and hopefully it will work. Currently, I'm using the Mac Pro, so it's supposed to be working in your iPad, iPhone, or any other Apple device.
Okay, I'll make sure to check it out again. If I have any more questions, I'll email you. Thank you.
Sounds good. Thank you.
Excuse me, Dr. Nader, regarding the letter of recommendation request in the app, there is a home and then request. So we request the letter of recommendation through the app.
So let's see. Yeah, so this is the app where you can add your bio. I think in your profile also you can add it. But the idea is if you go to the request, I want to add or update my task. For example, I did presentations today. So I'm going to add here, I did 3 presentations, whatever. And then you save that. That would be in your list of things for me. I'm going to go back and look at your task or whatever you did in the fellowship. When I'm writing the letter, I can reference you did this, or some of them in your letter. So it will be personalized, if that makes sense. So for you guys, it will be showing like this. You request a letter, but in this part, I want you to show me exactly what you did. You list whatever you did during the fellowship so that I can add some of this in the recommendation letter, if that makes sense.
Thank you so much, Dr. Nader. That was very informative.
Sure. Thanks. Any other questions?
Yes, Dr. Nader, me and Dr. Rahma, and I'm sure a lot of fellows asking about this. She said that she really appreciate if you can talk about how to stay positive and confident during this process. All of us are going through very stressful and challenging condition. So a guide regarding how to manage the upcoming 2 months is really crucial, and any advice from your side will be highly valuable. Thank you, Dr. Nader.
You're welcome. Thank you for the question and thank you for attending the meeting. So the idea is you do your best and the rest will be on God's hand. Like Allah will make it when it's right time for you guys. So can I just share with you my experience? I came here, I did my steps. I didn't pass step 2 first time. I passed it second time. I had low scores. That's many years ago. And the competition for me was so difficult. So I tried to do some research. I did clinical experience, a little bit observership, medical assistant, different things, but I joined a research lab center where I did 4 years. And during these 4 years, I helped that center, but at the same time, they helped me build my resume. And I did a postdoctoral fellowship 1 year at Harvard. That also made a difference in my resume. When I applied, then my application was a little bit competitive in that sense. And they wanted someone to complete the task. Basically, they wanted someone to do the job immediately. And there was an open spot that I was lucky to be interviewed for that spot. And my interview was almost June time, and they got me accepted within 1 week or so. I have to move from Buffalo, New York to New Jersey, find a place and start in 2 weeks. So this is my experience. But for you, hopefully it will take you less time and less effort. So what I advise you guys is to work on, if you have time, your clinical experience here in the US, if you are inside the US. And this is very important. You already passed the test, USMLEs. If you have time to prepare and take step 3, that would be a very plus sign that you are able to pass the board for them after 3 years when you finish your residency. And it's required after the first year. So you will save them a headache if you have that step 3. The second thing, the research part is important. So if you can get involved in different research projects, the app development, for instance, if you have time to work on any poster in the coming days, weeks, we can apply to or submit to some conferences. That might be also some option. In the program here, you can be a leader for a team. You can start together a workshop about a topic that you can share with the residents, with the fellows here. For the community, you can start a webinar with some of the fellows here, or you can invite some of the physicians that you might know, 1 or 2 about a topic. You create a timeline, and then you can work on that. All these activities can be done. And last year, the year before, some of the fellows here did some of these. So one fellow, Akila, she participated in 3 clinics in different cities in the US. She and her team here started a webinar. And I think she was involved in different research projects as well. So she published some. So you can try that. The last part I would advise you is you need to practice with maybe some of the fellows here. You can create small groups, 3, 4, and you work together on your own time. You can create the team from your color team, or you can create your team from people around you in the same area. If you are in Texas, for example, you can see people who are in time zone similar to you, so that after work you can do, or during the weekend, you can work together. It's better to give each other feedback and see how you can improve on your interview skills, your body language, your camera, your smile, the way you answer questions. You don't have to memorize, but you need to understand the details or the ingredient of your answer. And also try to lead the interviewer with some part of your answer. So, for example, they ask you something, you have the option to answer to that question with limited answer specifically for that question. But I would advise you lead them, so you add part to that answer where you leave a door open for them to ask you more, where you want to speak more. For example, if you participate like Granda, for example, she and her team are developing this app about diabetes. If the question about something unrelated, somehow in the answer to that question, she may add, and that's a good opportunity for me, because I led a team, or I worked with a team in this program, geriatric, and we were developing an app that helps patients with diabetes. So by that, you will drive the attention of the interviewer to ask you about, tell me more about this app development, so you can talk more. There are some videos in the app about interview skills, different ones. Some of the fellows did some of them in the past, and some we collected from YouTube. So they are available also for you guys. I hope that will help, but just try your best, and hopefully you will match. If you have some red flags, if you graduated more than 5 years, or if you have trouble with some steps like taking the steps of lost course or this, that, then you can try to figure out how to answer questions about these red flags. The method to do that is to admit that you know that you did a mistake. For example, I did not prepare well. You don't have to excuse yourself. You don't have to mention I was sick or my father or whatever, but think about how you overcome that. So you mentioned that I'm really interested in improving my knowledge, and now I'm attending the weekly seminar here, or I'm doing CME courses, I'm doing online courses. I'm trying to get up to date with my topics, something like you show them that you are improving in your knowledge. And if you are preparing for step 3 or you took step 3, show them that and to improve on my clinical skills or knowledge, I am preparing or I took step 3, something like that, if that makes sense. Thank you.
Thank you, Dr. Nader. That was so much informative and cheerful. Thank you for your time.
You're welcome. Anytime. Wish you all the best, all of you.
Thank you so much, Dr. Nader. I just wanted to maybe throw this out there and try my luck. I'm applying for OB. If anyone here applied in OB or is working, can help me get an observership, or because OB is a very competitive field and I have not found a lot of IMGs in OBGYN. So if anyone can offer any help, any sort of connection, any sort of anything, I would really appreciate it. My name is Dr. Sara. I'm in Team Fuchsia. If you can help me with anything, I would highly appreciate it. Thank you so much.
Thank you all again. Thank you, Dr. Saja, and your team of presenters. Thank you all attendees from today's meeting. I wish you all the best. Have a wonderful day. See you next week. Assalamu alaikum.
Alaikum salam. Thank you, Dr. Nader. Have a great rest of your day.
You too. Thanks. Fi amanillah.
Thank you, Dr. Nader.